Thank you so much. Some of you might have noticed that Dr. Peregrine has joined us. I hope he's here to support us and not to judge. No, thank you. Seriously, thank you very much. So I'm really going to present two talks that I gave in September at the American Heartworm Society Symposium with a little bit of modification for a Canadian audience. So this was New Orleans. It's an interesting place and lots of interesting stuff to do. And it's a really great conference. If you do have an interest in heartworm, it's one of the best conferences I know. Everyone sits in the same room for, I think, 3.5 days solid and just listens to these 20-minute talks from all the way from like basic research to sort of emergency care of cavil syndrome. So I just wanted to get a bit of a feel for where we are in the audience about heartworm. Is anyone here treating heartworm on a regular basis? Okay, there's a few. And just by a show of hands, are you primarily using melarsoline or the slow kill protocol? Okay, both. Some are doing both. And what's your level of confidence treating heartworm? Would you say is high or low? In between, some okay. So I think just because most people are not treating heartworm, I'm just going to quickly run through the life cycle. Just so that it's, because there's some issues around the treatment that are relevant to the life cycle. So start off at the top here. Once there are microfilaria in the dog's bloodstream, which obviously only occur if you have a male and a female worm if you have a male and a female adult worm in the dog, you end up with a microfilarial immature stage in the bloodstream. That's picked up by the mosquito when the mosquito feeds on the dog. What's very cool about this parasite, and most parasites, they're these really intricate life cycles. So the microfilaria has to transition to the next life stage in the mosquito to be able to be transmitted to another dog. And that's really relevant because this is a sneak preview. If the dogs had doxycycline, that actually blocks that developmental transition. So there's some very cool stuff about heartworm treatment. The mosquito then the transition then turns the non-infected microfilaria into an infected microfilaria. The mosquito then feeds on another dog and essentially injects that dog into the microfilaria into the subcutaneous tissues of the dog, and then that sits around for a couple of days to get from the L3 to the L4 stage. The L4 larvae end up migrating through the tissues, and then they become sexually immature adults at about 2 months, and ultimately they migrate to the heart and lungs and become the mature adults at about 6 months to 7 months, and that's the reason for waiting 7 months before you'll, for example, test a puppy. I also want to point out this is primarily a lungworm. It's called a heartworm because heartworm, when the worm is in the heart, that's the most dramatic presentation, but most of the time, I think I'm correct, they are in the lungs. They'll only sort of fall back into the heart where there's a really high worm burden. The other really, really interesting thing about this parasite is that they live with a bacteria called Wolbachia, and that is an endosymbiont. It lives inside the heartworm. It's in all the heartworm life stages, but it passes from the female worm to the eggs. That's the only way it kind of keeps going. So it doesn't sort of go between different worms from like different places. It's quite interesting. And that is a symbiont. So the heartworm benefits from the Wolbachia, and the Wolbachia benefits from the heartworm. The heartworm is unable to reproduce normally if it doesn't have the Wolbachia in it. And that's where the doxycycline comes into the treatment protocol and why it's so important. So, I mean, I'll just mention it right now. Like for me, just given what I know about both this symbiosis as well as what happens after treatment with melarsoline, it's absolutely essential to include doxycycline in any heartworm treatment. I mean, there are ways to take some shortcuts, but I don't think that's one of them. And then just a quick word about heartworm preventives. I'll talk about macrocyclic lactones along the way. They are, or MLs. That's just all of the classes of drug that we routinely use for heartworm prevention that I think everyone's familiar with. So selamectin, selamectin, ivermectin, and then moxidectin, which is, there's really three basic types of moxidectin preventives, which is Advantage Multi, which is the topical, ProHeart, which is a sustained release injectable, and then Simparica Trio, which is the oral form, which also contains moxidectin. So that's the background, but please feel free to interrupt at any point and ask if something's not clear. So the first talk that I presented at the symposium was, the title you'll see was based on this publication that came out a little while ago, which was called Variation of the Adulticide Protocol for Treatment of Canine Heartworm Infection. Can it be shorter? And this group treats with melarsoline after 30 days compared with the American Heartworm Society recommendations of waiting 60 days, and I'll talk about that a little bit more soon. So we kind of made the title very similar, and we're going to try and publish this title. We'll see if we can get away with it, called Further Variation, and can it be even shorter and cost less? So heartworm in Canada is generally considered to be very rare. So in population surveys, it's about 0.1 to 0.2% of all of the dogs that are sort of routinely tested at conventional vet clinics. Like many other shelters, we transfer dogs in from all over the place, and particularly from underserved communities in Ontario, mainly First Nations communities, and then partners in the southern US. So because of those transfers, we actually bring in quite a lot of heartworm positive dogs. We, I would say, never get heartworm positive dogs from the city of Toronto without a travel history, and all of our heartworm dogs come from somewhere else. So we've probably treated about 200 dogs so far over the past some years using the 3-dose melarsoline protocol. The American Heartworm Society protocol, just very briefly, on day 01, which is the day of diagnosis, they say you should start exercise restriction based on the clinical signs. There's a course of prednisone that they recommend, and then doxycycline 10 milligrams per kilogram twice a day for 28 days, and then a monthly heartworm preventive. Then at day 61, the first melarsoline injection is given, along with a 2-week course of prednisone, and then strict exercise restriction. This is the point where the worms are going to be dying quickly in large numbers, and where the likelihood of pulmonary thromboembolism is the highest, is after the melarsoline injections. So if the dog goes running around, there's actually a fairly good chance that they might just collapse and die because of rapid and catastrophic pulmonary thromboembolism from these dead and dying worms. Then a month after the first melarsoline injection, the second and third melarsoline injections are given back to back, 24 hours apart. And the reason they ended up with this protocol is it splits the worm death into sort of 2 chunks of about 50% each. So you're not killing all of the worms all at once, which will lead to much higher likelihood of pulmonary thromboembolism. At that point, another course of prednisone is recommended for 2 weeks, and then strict exercise restriction for about six weeks, maybe tapering off, and then ending for sure after 8 weeks. They also recommend doing the antigen test combined with the microfilarial filtration test 9 months after the third melarsoline, because in rare cases, some dogs can still test positive after what we used to do. They used to do it at 6 months. We still do it at 6 months, but every now and then a dog will be positive at 6 months, and then people won't know what to do. So they said, in a dog in a home that's doing fine, there's no real reason to do it sooner. So they recommend doing that at 9 months. So the 60-day delay to melarsoline following diagnosis. The reasons they give for that is to allow time. Once you give the doxycycline, it's been on board, you've given it for a month, it's been on board for a while. They want to clear all of the Wolbachia, and make sure that none of their proteins and metabolites are still hanging around, because those cause inflammation after worm death. And then they say in their guidelines, this may further weaken the worms. It's not really super based on evidence, but that's actually the wording they use. And then they used to talk about a susceptibility gap where the treatment wasn't going to kill those sort of those late immature stages. So we want to look at a shorter interval, and I think Dr. Ward gets the credit for this. She was really looking at reducing the length of stay in shelter care, as well as having a shorter duration of exercise restriction. So at the time, we talked to a lot of experts, including Dr. Peregrine, and we got what we thought was a reasonable amount of support for our approach to this. And there's been more support for how we've done it in the years since then. So first of all, there was a very, very good paper that was published in 2017, really kind of debunking the whole susceptibility gap, that with the treatments that are currently used, there really isn't one. So that reason for the 60-day delay has actually been removed from the American Heartworm Society guidelines in the last few years. This paper also argued that if you wait 60 days, these worms are growing sort of fairly exponentially, so you are increasing the likelihood that they will cause more inflammation and more obstruction of the pulmonary vessels, as well as more severe pulmonary thromboembolism. So they were actually arguing for treating with melarsomin right away. And then I talked about the previous work that had supported a 30-day interval from diagnosis to melarsomin. The other thing that I guess I got a bit exercised about in the very beginning was the fact that they were using doxycycline 10 milligrams per kilogram twice a day. So we had treated a lot of ehrlichiosis back in South Africa, and there was always 10 milligrams per kilogram once a day. And looking around, most applications for doxycycline are 10 milligrams per kilogram once a day. We could not find a whole lot of evidence for this. If you look at the different guidelines, the European ones and the tropical ones and whatever, there really isn't consensus on the frequency. What the twice a day is based on is that they have proven that twice a day works. Nobody's ever really looked at it quite in the same way for once a day, but it seems as though there wasn't really a strong reason to use twice a day rather than once a day. And obviously you have increased GI side effects, you have increased costs, you have increased labor by shelter staff giving twice a day meds rather than once. So the main adjustments to the American Heartworm Society guidelines and to this other study I mentioned that we made some time back was that instead of giving doxycycline 10 mg per kg twice a day, we give it once a day. And then we start melarsomin, at least in theory, on day 14 following diagnosis. So at that point, the dogs had 2 weeks of doxycycline. We always complete the 28 days of doxycycline, but we start the treatment in the middle of that period. We still test, we do the antigen test, or we recommend the antigen test is done 6 months after the last melarsomin, and that completes our whole protocol at 7.5 months after diagnosis compared with 12 for the AHS. So we had good experience with this protocol, but we all know that like memory is really not a great tool. You often remember the best things and the worst things and not everything in between. So we retrospectively assessed the results of our protocol on 157 dogs. So they all had asymptomatic or mild heartworm disease at presentation. And we had thought that most of them started their melarsomin at 14 days, but actually when we looked at the data, the ones near the beginning of the time period had actually had the American Heartworm Society protocol. So serendipitously, we were able to compare the two protocols, which was amazing because there's very few like randomized controlled trials in heartworm, and this wasn't randomized obviously, but it was actually, we were able to sort of compare these two things head to head. This is a little bit complicated, but just to show you, we ended up with, we took 14 days and then 7 days on either side for the first melarsomin injection as our protocol, and then we took 60 days with 7 days on either side as the American Heartworm Society protocol, and that was groups A and C here, and then anything that sort of fell in between, we just put into two other groups. We didn't really do much statistical comparison with those other two groups, because of the sample sizes, and we were really interested in our protocol compared with the American Heartworm Society protocol. M1 means the first melastomine, M2-3 is the second and third melastomine, and then MFT is the microfilarial filtration test, or the NOTS test. We also looked at the respiratory signs or other signs at different treatment periods. So treatment period 1 was before melastomine, so obviously everything that happened in that treatment period had nothing to do with melastomine. And then treatment period 2 was between the first melastomine and the second and third, and then treatment period 3 was after the third melastomine. So we had 79 dogs in our group, 27 in the American Heartworm Society group, and then everybody else was in the other groups. Then we looked at, this was a retrospective study, so we were using data from the shelter and data from foster parents and so on. We ended up deciding to include anything that was ever mentioned because we didn't want to bias the study results by saying, well, if they only mentioned coughing once, it doesn't count or whatever. So we had a very wide definition. It was really if a cough was ever reported, if increased respiratory effort was ever reported, and then suspected pulmonary thromboembolism would have been diagnosed at the shelter. But a lot of these dogs would never have presented at a veterinary clinic for a lot of these problems, which I just wanted to point out. So we looked at pre-existing respiratory signs, new respiratory signs. Complications were considered to be respiratory signs that needed extra treatment compared with what we were already doing, but that could just be extra prednisone. It wasn't necessarily anything particularly complex. And then GI signs we looked at before melastomine because we were interested in what the doxycycline was doing, and there was just vomiting or diarrhea. So as far as the melastomine results were concerned, this is actually just everybody. What was quite striking here is that you look at treatment period 1, more dogs were coughing in treatment period 1 before any melastomine treatment than at any other time. And there's various reasons that could have been the case. The red here is new clinical signs and the gray is pre-existing. So if a dog had a cough in treatment period 2 and it had already been identified as having a cough in treatment period 1, that was considered pre-existing. If it had never had that identified before, it was considered new. So there was mostly coughing going on, more during treatment period 1, some in treatment period 2, and then much less treatment period 3. Increased respiratory effort was much less common and really is following the same kind of pattern. Pulmonary thromboembolism was only identified after treatment, but only in a very few dogs. And then respiratory complications, again, they occurred during that first period in most of the dogs, and then continued in a lot of dogs, in a fair number of those dogs, sometimes the same complications, sometimes different complications. So in terms of what we could compare, for new respiratory signs after melastomine, we could compare the number of days before melastomine for the groups that had new respiratory signs and the group that didn't. You can see that the ones without new respiratory signs often had their treatment later on, but there's a wide overlap between the groups and there was no statistically significant difference between them. And then this graph shows the purple is respiratory signs and the red is complications, and group A is the group treated with early melastomine, and group C is the AHS group treated at 60 days-ish. We could only compare the new respiratory signs because there were too few complications for statistical comparison. We had 11.4% new respiratory signs after melastomine in our group and 7.4% in the AHS group, and no statistically significant difference between them. And then as far as doxycycline was concerned, we had very high rates of vomiting and diarrhea, partly because of that very liberal case definition and partly because it's a shelter and then probably many of them had GI signs for other reasons. But there was no statistically significant difference between dogs that had once a day or twice a day doxycycline, which are a little bit surprising, but what you could argue is a clinically significant difference with quite a lot more dogs having GI signs after twice a day doxycycline. And then in terms of whether doxycycline affected the safety of the protocol, whether treating earlier, whether treating only once a day doxycycline, whether that affected the safety of the protocol. This one was a really nice result, where really virtually the same percentage of dogs on once a day or twice a day doxycycline had new respiratory signs after treatment. In terms of outcomes, everybody was treated successfully to discharge. The only dog that wasn't adopted was a foster dog with chronic kidney disease, and that dog was successfully treated for heartworm and euthanized for the chronic kidney disease about a year later. Many of our adopters did not retest them when we told them to, or not at all, which was really disappointing. So eventually we were able to follow up on 44, some of whom we persuaded to have the tests done. And anybody who was retested more than 3 months after treatment tested negative. So we felt that the findings supported initiating melarsoline early, so in our case 14 days, and using doxycycline only once a day, and the reason being that this improves quality of life and shelter life-saving capacity. Okay, so the second talk was about moxedoxy as an accessible alternative to melarsoline. And I thanked and will thank again Dr. Hornak, who started us on this whole journey. And then there's a person called Jeannie Goldring, who runs an organization called the Inner Pup in New Orleans, and they do heartworm prevention and treatment using the moxedoxy protocol. So some of this was sort of geared at an American audience. We were hoping to have Canadian data about this within the next year or so, and it probably won't be as dramatic. But there was a study done in 2018 showing that about a quarter of American households experience barriers to veterinary care. Many of these households also rely on government assistance just to buy food. So there's very significant poverty, and especially in the Mississippi Delta, where in their case there's a ton of heartworm. We pointed out that in Canada, many dogs live in remote areas that have no veterinary services, and some dogs don't live in remote areas but also have no access to veterinary services, largely in the indigenous communities, but also in underserved communities where people just can't afford veterinary care. And so there are many dogs that just don't see a veterinarian and really don't have typical access. So there's been a lot of controversy about moxedoxy and other so-called slow kill protocols, and really the argument we put forward there is that for dogs like these dogs, this was a dog presented at one of the Inner Pup clinics for a heartworm test, that they're not looking at a choice between melarsoline and moxedoxy. They're looking at a choice between moxedoxy and no treatment at all. And if that's the choice, and you've got a treatment that's quite safe and effective, then it seems very unreasonable to just leave them to die, which in effect was the previous option. So what happened was, as a result of getting entangled with Tammy, we ended up looking into moxedoxy in a quite a major way, and it became very clear that there was no place where there was information about the moxedoxy protocol that was easy to find and just all in one spot. So that led me to write this review with Brian DeGangi from ASPCA to really just try and clarify what is going on with moxedoxy and try and provide some evidence-based guidelines. So this has actually been, it was a painful experience. The heartworm literature is horrible, but this has been published open access in Frontiers, and it's had like I think about 30,000 views so far. So it's really had wide readership, and at least it provides the information so people can make more informed choices. So what moxedoxy is, it's one of the so-called slow kill protocols, which is a combination of a macrocyclic lactone and doxycycline. Brian likes to call it the alternative adulticide treatment. Unfortunately, I think slow kill is probably there to stay, but we sort of try and call it alternative adulticide. Because slow kill to some people means, oh, it's slow, so it's safe, and to other people it means, oh, it's slow, so it's not safe. It sort of has a judgment to it. So the two that have been used are ivermectin and doxycycline, and then moxidectin and doxycycline, which is colloquially called moxidoxy. So back to access to veterinary care, there's a very striking correlation between poverty and really every infectious disease, as I think we all saw during the pandemic, and this is very, very true of heartworm as well. So dogs that don't see a veterinarian on a regular basis in a heartworm endemic area are much more likely to have heartworm because they're not going to have preventives. And so these are just a whole bunch of examples of unowned or shelter dogs and heartworm prevalence. And you'll see here on the right-hand side, for me, that outreach clinic dogs in Canada had a prevalence of 18%, which is really a hyper-endemic amount of prevalence within a country where the overall prevalence is 0.1 to 0.2%. So this represents dogs in indigenous communities who, in the normal course of events, have not had access to veterinary care or preventives. And this is where clinics like Dr. Hornak's and Dr. Bolton's and Dr. Ward's are making such a difference by actually getting into those communities and providing preventive care as well as treatment where it's needed. So yes, so really our position is that the best care for an animal is care that is safe, effective, and appropriate for that individual animal, that individual client in their specific context. I found a framework on Twitter about COVID during the pandemic where they talk about risk, benefit, context, and alternatives. And I think that's such an incredible way of looking at veterinary care because it will be different depending on that particular animal and that particular family and what the alternatives are. We call it BARC because it's B-A-R-C, even though the order doesn't make sense, but it means it's easy to remember. So the issue is, if you say, you know, what's best for an animal is what's safe, effective, and appropriate, then that comes to the crux of the whole moxie-doxy controversy, because a lot of people think it's not safe, effective, and appropriate, and they think it's really sort of substandard medicine and unacceptable. So before I get into the specifics of the objections, there was a question about whether people using a slow kill protocol should use ivermectin because it's much cheaper than moxidectin. So I took 3 studies that all ended at 9 months. Ivermectin alone had 20% efficacy against adult heartworms. Ivermectin and doxycycline had 75% efficacy, and then moxidoxy 95% by 9 months. So in my view, ivermectin is a false economy and not really an acceptable alternative because it does take so long and there's going to be a pretty large proportion of dogs that are never going to clear. So I don't think that ivermectin is a reasonable alternative. Some shelters, and we spoke to a few of them while we were there, they don't treat with melasmine in the shelter because they're worried about pulmonary thromboembolism because the dogs are jumping up and down. It was quite concerning. Apparently it's quite a common practice that they will wait until the dog's adopted and then offer melasmine treatment in the home. That means those dogs can be sitting there for months, those worms just growing and reproducing. So that also seems like a problematic approach. So even if they were using ivermectin doxy, they would probably be better, but if they could use moxidoxy in the interim, if they're afraid to use melasmine, some of those dogs will be cured by the time they leave the shelter. I think that's sort of a project for somebody down in the American South, probably Brian. The key to our review was really the published moxidoxy studies. So there's a body of evidence now for moxidoxy and a new one that was published in 22 since the review. So most of the studies used topical moxidectin. There was Advantage Multi, and then one used slow release subcutaneous, which was ProHeart 12. That represented 128 dogs. Some of them had control groups, most of them didn't. And on average, the efficacy at the end of these studies was about 97%. So pretty high, and all of the dogs were cleared in a fair few of these groups. There was only one experimental study. What they do is they provide absolute proof that the infection was cleared. So if you do an antigen test, there's always a possibility that you could have a false negative antigen test after moxidectin and doxycycline, as opposed to if you do a necropsy study and retrieve worms from the heart and lungs, you know for sure are they there or are they not there. So this particular study, they had 8 dogs that were infected and all the dogs were infected. They treated 8 dogs and they didn't treat 8 dogs and the dogs with they were treated with moxidoxy. 5 of 8 dogs had cleared the infection completely by 10 months, and the other 3 had either 1 or 2 worms. So in these studies, they look at efficacy by the percentage of worms that are gone. So it's a little bit different, but still very high efficacy. And this is the only study where you can sort of prove beyond a reasonable doubt that the worms really were killed. In terms of formulations, there's not much information yet about subcutaneous versus topical versus oral moxidectin, and this was presented at a recent conference that Dr. Peregrine was at. So thank you for this information, and it's very preliminary. We don't really have the details of these studies, but just from the little that they presented in the abstract, it looked like injectable and topical were about the same for moxidoxy treatment, whereas oral was less effective, which is fairly likely because the dose in the oral formulation is very low. One of the big arguments about using moxidoxy and why it's a bad idea in a salvage treatment is because the concern is that there'll be progression of pulmonary pathology during the treatment period because the worms are dying off slowly. When you talk about slow kill, it's not as slow as it seems to be. So I'll try and explain this. So the top section is melarsomin treatment, and then the bottom section is moxidoxy. With the melarsomin treatment using the American Heartworm Society protocol, and I wish I had a pointer, the melarsomin is given at the end of the second month, and then the second and third melarsomin treatment is given at the end of the third month. So you get about 50% worm death within 1 to 3 weeks of each melarsomin treatment. So pretty much all of the worms in nearly all the dogs are going to be killed by the end of the 4th month. So you've got a worm-free dog from 5 months onward. And then the antigen test can be reliably assumed to be negative in nearly all dogs by the end of month 9. For moxidoxy, you're giving the moxidectin every month. You have to assume, because nobody really knows exactly, but there's probably gradual worm death happening over a period of months. The antigen test in most dogs is negative by the end of 12 months. And assuming that's not a false negative test, which could be argued, but it won't be a false negative in most dogs. If you trace that back a few months for the antigen in the dog's blood to decline to undetectable levels, you probably have most worms dying by the end of about month 7. So with the current American Heartworm Society protocol compared with moxidoxy, there's about a 3-month difference for most dogs before all of the worms are dead. That's not a dramatic difference. When you think about slow kill, people are thinking it takes maybe a year or 2 for all the worms to die, and it's actually much quicker than that in most dogs. So as far as progression of pulmonary pathology, first of all, the worms are not taking as long to die as one might think. There's probably less risk of massive pulmonary thromboembolism because the worms are dying gradually, not all at once. And then doxycycline, as I said before, is really critical to reducing pulmonary pathology. It massively reduces the inflammatory response to the dead worms. Because what we're doing is we're taking a sort of a fairly stable situation, we're killing the worms, and then they are releasing massive amounts of inflammatory mediators, as well as breaking up and embolizing. So the treatment all by itself is causing potentially a fair amount of damage, and then the doxycycline reduces that dramatically. So we went and tabulated all of the clinical and imaging changes in the respiratory system that were reported in all of the studies, and they were mild in all studies. So I think there was one dog in all of those studies that required, I think, 1 day of hospitalization. And I won't go through this whole thing, but this was one of the experimental studies. but the authors actually said that the treatment protocol was really well tolerated, with no clinically relevant effects detected for biochemical, pathological, or imaging variables during the 10 months. And they also said that the histopath changes in the lungs were really as expected for any adulticide treatment. So it just seems as though this progression of pulmonary pathology concern is not necessarily as dramatic as might be assumed. There's also a concern about, can you exercise restrict a dog for 2 years or a year and a half? And the American Heartworm Society recommends strict exercise restriction for the entire moxidectin protocol. Most of the studies had no exercise restriction or minimal exercise restriction, and they still had really good results. So really in the review, we kind of said, if the dog is symptomatic, you should really counsel the owner to try and exercise restrict them to the extent possible. But it's going to be to the extent possible, and a lot of these dogs are not going to be exercise restricted, and they'll do fine regardless. There was also a concern about microfilarial resistance, with the idea that you have subtherapeutic doses of preventers for long periods that would somehow lead to resistance. And there's not a lot of literature on microfilarial resistance. It doesn't appear to be increasing, and it mostly has been identified in the Mississippi Delta area and not in other places. And there are many other factors that promote resistance, including wanting 12-month prevention. I mean, they made the point that any parasiticide is going to run into resistance problems at some point, just because that's what happens. You have an interplay between the host and the drug and the parasite, and eventually resistance does occur. For moxidoxy specifically, moxidoxy is pretty effective against resistant strains compared with the other MLs. And then doxycycline, as I mentioned earlier, interrupts parasite reproduction. In terms of testing for efficacy of treatment, so we recommended in the review that it makes sense for most dogs to treat at about 12 months, because even though some dogs will test negative before that, most of them won't, so you would just be wasting time and resources if you test them earlier. And then to repeat approximately every 6 months until the antigen test is negative. We've said in a perfect world, you should wait until you have 2 consecutive negative tests before you call them negative, but it's really not essential. And then you could call treatment failure maybe at 24 months, possibly even 18 months. There have been some studies showing that dogs treated with macrocyclic lactones can have a false negative antigen test. So several of the studies used heat treatment, which separates the antigen-antibody complexes and makes the test less likely to give a false negative. But as with post-melarsoline, all that seemed to do was it would free up antigen, and then the test would be positive, but it wouldn't actually correlate with anything clinical, and then 6 months later the dogs would always be negative. So there was never a situation where a dog was antigen negative, heat treatment positive, and then antigen positive 6 months down the line. So none of the studies recommended heat treatment. So the main recommendations that we ended up with, and this was really I wanted a table like this that I could refer to. So this was the primary point of the review. It's a sort of a go-to, so this is what you need to do, here's your recipe. So we've recommended doxycycline once or twice a day for 4 weeks, topical moxidectin at label dose and frequency, not more frequently. There's certainly a lot of potential for sustained release subcutaneous moxidectin or ProHeart, but we've only got the one study, so really we're hoping for more studies just to kind of confirm that that's really effective. But it's incredibly attractive, to walk in there and just you give your preventive and you're done. In our case for 6 months, and where you've got ProHeart 12 for 12 months. Some of the studies stopped at 9 months or 10 months or whatever. It seems like if you're in an endemic area, you might as well just continue the preventive sort of forever, but at least until the first negative antigen test. And then there doesn't seem to be any benefit to repeating the doxycycline more frequently than once every 12 months. But it must be repeated. If you're treating for more than 12 months, you must repeat the doxycycline. Okay, and that was pretty much it. Any questions?